Good evening and welcome to tonight's In Conversation Live. Before we start, I would like to encourage all of you to use a Q&A function. This is very much a dynamic in conversation with our guest, and I will pass on every comment, every question that you pose. Our guest this evening is Dr. Chaand Nagpaul, the first ethnic minority chair of the British Medical Association Council and a general practitioner for over 30 years. He has been described as the most powerful GP in the country by Pulse magazine and was awarded a CBE in 2015 for his services to primary care. Welcome, Chaand.
Thank you very much, Henrietta. I'm delighted to be having this conversation with you.
Excellent. We're going to start with something very relaxing, but we're going to get on to quite serious politics later. So tell me, you were born in Nairobi, you moved to England at the age of 7, and you have been known to say, "What had my parents done, bringing me to this cold and desolate country?" Tell us, when did England become home for you?
Well, you see, I was living with a lot of relatives in Kenya, and they all moved back to India, but my parents came to the UK, and so we were already isolated in terms of a family structure. But what I remember is, I mean, Kenya is a sunny country, the houses are open plan, you meet people, there's a sound of people. And I remember coming here, we moved to Clapham, and we were living, my parents rented a first floor flat with 2 rooms in Clapham, which wasn't quite as attractive as Clapham is now. And I just noticed that I'd walk the streets and people wouldn't say hello. It was a cold weather. I also remember at the time, and it's very unfortunate that in those days, even race inequality or racism was pretty overt. There were signs on the windows of rented accommodation saying no foreigners allowed. There was violence against people of ethnic minorities and black people. There was something called Paki bashing. So I really thought, what have my parents done? Brought me to a country where we're not welcome. And in fact, there was a lot of obvious hostility in the air. But as time went on, I have to say, I've integrated. And in fact, first of all, I do think that we're not in the same place in the UK now as when I arrived in 1968. We have a much more multicultural society. But as I got to go to school, I went to secondary school, went to university, I have to say that I acquired a real sense of enjoying English culture whilst retaining my Indian identity. I developed friendships, got to know many people from different cultures, including those who were English. And therefore, I see myself very much embodying or living the values of multiculturalism. I love being able to listen to some Indian classical music, at one stroke, and then maybe tomorrow listening to some jazz music, and the same applies for watching a Bollywood movie and being just as relaxed watching a Hollywood movie the next day. So I very much have grown to enjoy being both Indian and being British.
Beautiful, beautiful. I love hearing that story. Having read that quote, I was very curious to know. So let's move on to your role at the BMA, your leadership role, particularly thinking about the pandemic. There must have been some extremely challenging times, and we very much want to hear about them. Want you to share with us what you've lived through and what those moments were.
Sure. And Henrietta, may I just start by saying that I first attended a BMA conference back in, gosh, I think 1992. I was just recently qualified as a doctor, and it would have been beyond my wildest dreams that I would ever chair the BMA and go on to, when I did chair it, preside over a once-in-a-generation crisis of the pandemic. But the pandemic, I think has left me and I know the medical profession with many scars. And back in February, March, I recall watching the scenes in China and then, of course, in Italy, in Lombardy. And I just could see that this was going to spread to the UK. And what I did at the time, I did contact the government. I spoke to the chief medical officer, and I was hoping that we would, in the UK, with this advance notice, remember we had notice compared to Spain and Italy, that we would have things put in place to protect both our nation and protect healthcare workers. So it came as a real shock when we started to see the virus properly take hold in the UK. We're talking about, early March. And although ministers on television said, we have enough stockpiles and we will deploy these protective equipment to you as doctors, I believed it. I genuinely believed that it was all taken care of and that the government was prepared. But as the days and weeks went by, in fact, the days went by, we started seeing people becoming seriously ill, dying. And what I was finding was I was being bombarded by doctors across the UK, telling us and telling me that they just were unprotected, that the supplies weren't there. And I remember one particular episode when I was actually traveling to the BBC studios to do a Newsnight interview. This was very much in the early part of March. And I had one doctor ring me up as I was in the taxi saying, I'm being asked to go into a ward without a face mask. They say there's none in the hospital. What do I do? And I felt for that, the doctor concerned, because I knew, and we all knew, that this was a situation where we had a deadly virus. We had there was no vaccinations then, there was no treatment, and we could see the impact of this virus literally making people ill or people dying. I also remember at the time, I wrote a letter of condolence, actually, to the head of the Italian doctors, because in Italy, we'd seen about 50 doctors die. It hadn't crossed my mind that we would actually be in exactly the same place. When I sent that letter of condolence, I just assumed that with the advance notice, we would be better prepared. So I think that one of the real shocks was that we didn't have protective equipment. And if you remember, what we were told at the time by government was that it was about supplies not being able to be transported, that in fact they were all there, but it was difficult to transport supplies to every part of the UK and to so many hospitals. They'd never done this before, and that the army would be drafted in. Again, I believe that. We believe that at the BMA. But again, as the days went by, it became clear it wasn't just an issue of not having transport. We didn't actually have the stockpiles to protect the medical profession. I remember that we had an emergency meeting in myself and other medical leads with NHS England just before Easter, when in fact we were going to be running out of all gowns in the UK. And there was a shipment from Turkey that we were actually depending on. And when it arrived, because these were like last minute procurements, that shipment had equipped a PPE that was unusable. It was below the standards. So doctors were unprotected, and that should not have happened.
So looking back, and I can only imagine, now the tension, the stress, the trauma that you yourself upon your shoulders, and we're not fully out of it yet, but I would imagine in years to come you will have even more clarity about what you personally are going through, representing this medical body that has been so hurt, harmed by all this. But looking back, that window we had when our Italian colleagues were calling up and saying this is what's happening, the recordings on the mobile phones that are arriving from the wards in Lombardy. Looking back, with hindsight, what should have been happening? Why were we so unprepared?
Well, first of all, every government should have pandemic planning and preparedness well in advance of a pandemic. You don't wait for the pandemic. That's the whole point of preparedness. And what was clear is that the previous exercises, Operation Cygnus, for example, just had not factored in the volume and stocks that were needed. That was one problem. But once we knew in February, in fact, in December, we knew what was going on in Wuhan, but in January and February, what I believe should have happened is that the government should have done two things. One, actually try to procure the PPE then, not trying to procure it in the middle of a pandemic and then trying to get supplies from Turkey at the last minute. It should have then made a concerted effort. There was also the ability for domestic manufacturing that could have started in February, knowing the situation.
And do
the other
you feel, sorry, I'm going to interrupt you for a second. Are you suggesting maybe that they had underestimated the vulnerability of the country to the epidemic arriving on our doorstep? Is that a possibility, that they had not envisaged this happening? Or do you believe they saw it happening, but they didn't pursue those measures? I'm just interested in your opinion on that.
I mean, I really find it hard to understand why the government had not prepared in those weeks, and I don't know which of the two answers is right. But what I do know is I remember my parents having to come here from India as an emergency because of the pandemic, and in fact in India they were locking down. And when they arrived here, and I knew, and this was the case for everyone, there were no checks when people came to the UK. So in fact we had a nation that was in many ways, it was allowing people to travel from Italy, and there were no checks as they came into this country. So there was a sense of, I just found complacency about the reality of this very deadly virus. And the other thing we didn't have was a public health infrastructure. We've had about £800 million of cuts in public health over the last 5 years. So we didn't actually have the testing capacity. And one of the things you do in a pandemic, in any viral pandemic, is that you contain the virus by testing and contact tracing and isolating. Yeah. And I remember again in March, we had Tedros from the World Health Organization telling the whole world that what needed to happen was test, test, test. I don't know if you remember that mantra.
I do.
And what we were doing here on the 12th of March, I remember the date very clearly. The government announced that they were stopping community testing. So the virus was effectively being allowed to spread and propagate, unchecked, with no one knowing who had it and who didn't. So you couldn't actually follow basic public health principles of containing the infection. Now, at the time, there was not really openness as to why the government took this approach. I think they said, well, there were too many people infected, but it later transpired. And of course, I think some of us knew that it was because we didn't have the testing capacity.
Right.
Countries like Germany did have the testing capacity. And then what the government did at the last minute was procure at huge expense private providers to try and do the testing. And that failed dismally. And, the figures were showing that private labs were only being able to contact trace about 60% of infected people. Whereas compared to the public health laboratories, this is the state-owned public health local laboratories, were contact tracing up to 98%. Now, that just shows how successful we are as a nation in having a proper public health system. But that public health system has been really eroded in recent years, which is why we didn't have the capacity. And this is one of the lessons the government must learn and make sure we put in place a properly resourced public health infrastructure that we know is highly effective.
So this last point is vital, isn't it? So what you're saying is that it was an erosion of the commitment to funding for future events that led to much of the disaster that you have just recounted now. And so in terms of learning lessons, that particular point about preparing and investing in order to be ready next time, that's very, very interesting. We've got our president, Roger Kirby, asking, could you comment on the decision to relocate patients from hospitals to old people's homes without COVID-19 testing, please?
That was such a painful episode for the nation, because we knew this virus was deadly. We knew that the most vulnerable were older people. We knew that, and those with medical conditions. And because we weren't testing, and because the government hadn't the capacity to test, it actually made this decision, as Roger has mentioned, of moving patients out of hospital into care homes, bringing the infection into care homes. And there's been an estimate. I mean, when we look at the mortality figures of the UK, which were in the first wave, one of the highest in the Western world, there's been estimated, I think 20 or 30,000 of those deaths were accounted for in care homes. And when I was I remember doing lots of interviews at the time, talking about the plight of lack of PPE for doctors and healthcare professionals, I actually in the same breath, felt that social care and staff in care homes were left absolutely vulnerable, because there was a time when PPE was being prioritized for the health service, but all our colleagues in care homes did not have PPE. So it was a really difficult time. And I do think that that was a real something that the government really needs to learn from. It used words like talk about an iron ring around care homes. That just wasn't the case. The infection was being brought into care homes and allowed to spread. I mean, the other thing to say is public health decisions that the government made in the early stages. You know, the decision to delay lockdown. You know, even in the BMA, we actually stopped face-to-face meetings a week before the government decided to actually make an announcement about this. You know,
do you know why they delayed it so much? Did that ever transpire? People are still wondering.
I have no idea.
Mm-hmm.
I think, you know, and whether it was about whether there was an element of denial, you know, allowing the Cheltenham races to go ahead, for example, I just cannot fathom it, because the public health reality, when you looked at Italy, was clear that we needed to contain the virus, and allowing people to mix when the virus was already in the community in this way was bound to increase spread. And again, there have been estimates of estimates of thousands of people who have unnecessarily died because we locked down late. And that's been a continual theme, especially in the first wave. And why, I mean, from my end, I just felt a sense of duty to really say what I believed the government should be doing. So yes, there were a lot of the BMA may have seemed to have been challenging, but actually this wasn't about politics. This really was about protecting the nation's health and protecting those that care for patients. And remember, one of the greatest things about the BMA is that we represented doctors across all disciplines.
Yeah.
And a lot of the input we had at the time was from our public health committee. And one of the, to be honest, I've learned so much epidemiology and public health medicine over the time. In fact, I was given an honorary fellowship of the Faculty of Public Health during the pandemic. So, you know, I feel I've become quite
you deserve it. You deserve it. You deserve it. And our gratitude to you for the role you held so committedly throughout the pandemic. But sorry, I interrupted you.
Yeah, no, but I was just saying, I really do take my hat off to our public health colleagues. You know, they were working 7 days a week, as I said, in a very under-resourced environment. And it was their advice and our conversations in the BMA where we could see that the public health decisions being taken by the government in the first wave just weren't following, you know, sound public health principles. You know, around containing the virus, about testing, and then, of course, decisions, even as we were coming out of lockdown. We were, in fact, probably the last nation in Europe to decide to require face masks to be worn, which was like, you know, bizarre, because we could see what other nations were doing. So there was a sort of sense of, you know, bucking the trend. And it wouldn't have mattered if you buck the trend, but you're actually at the same time doing well in terms of protecting the nation. But in fact, our illness rates, our death rates, our hospitalization rates were really the worst compared to comparative nations in those months of, you know, March through to about June.
Chaand, who were the heroes of that era in terms of information sharing, of giving us the correct evidence base, of being there for us to understand the facts? We know, you know, there were streams coming through social media, various figures, various advisors to government. Who would you rate as the top three?
I think at the time there were many sources of very good advice and evidence. I mean, I think that one of the great things about social media is we were getting other information, you know, alongside the government press briefings, and therefore we were in a situation where people could well, those of us who were interested in looking at the data could see the evidence, and there were many people who did come out and disseminated that parallel information, whether it was independent SAGE or whether it was other professionals. More recently, the ONS has been fantastic in really speaking truth to power in terms of the actual levels of infection. So I think that there was a big movement of people who and evidence and information that was coming out, and we in the BMA actually played our part. So we were putting out a lot of material that was giving maybe an alternative information about the reality affecting the nation, affecting the health service, and affecting healthcare workers. And one of the things that we did, in fact, I believe we were the first medical organization to call out the fact that, the first 10 doctors who died were all from an ethnic minority. Now, for me, that was like staggering. I couldn't get my head around this, that, the first 10 doctors were all from an ethnic minority background. I did an interview with The Guardian that was highly publicized, where I demanded, and rightly so, that the government needed to take action and do something about this disproportionate effect. And it wasn't just doctors. I'm a GP in providing care to a multi-ethnic population, largely Asian. And you know what? We were getting death notices of patients dying on a daily basis during March and April. And about every name was from an ethnic minority. I couldn't grasp this. And as a GP, I'd known some of these patients for decades. There was one day where we got the death notification for a mother and son, both who died of COVID on the same day in hospital. And we had a situation where 38% of intensive care beds were occupied by people from an ethnic minority background.
I believe that that Guardian article really shifted things enormously, and that was a very powerful thing you and your colleagues did by speaking up so well. I'll say so quickly. I mean, it was early enough for everyone to realize something dreadful was happening in relation to ethnic minorities, and so that was a memorable moment, as you say. Now, questions are pouring in. I'm going to ask you Joseph McMahon's question. Speaking to one of the military officers who was drafted in to deal with the PPE supply problem, he said that there was, in fact, plenty of material in the depots, but the NHS ministry bureaucracy was simply incapable of organising the distribution. Had you heard of that?
Yeah, so we were told that there were issues around distribution. And in fact, if that is the case, I think that's absolutely tragic. If there was PPE sitting in warehouses, which could otherwise have been protecting people, both in care homes, in the health service, and other key workers who never did ever receive PPE, bus drivers and so forth, who had much higher rates of death. So if that is the case, that's awful. But what I do know is that, and that should have been delivered. But in fact, as the weeks went by, it became clear that the total quantity of stockpile wasn't quite sufficient. But it's clearly wrong that it wasn't distributed when it should have been.
John Rudd says, does our eminent speaker agree that despite the monumental advances in medicine, the NHS has taken the wrong route, government-led, by not having local regional control, further not staffing correctly too many management administrators and not enough clinical staff? Now, Chaand, I know we were discussing a bit about your vision. Maybe when you answer, you should talk about your ideas about the NHS.
Yeah, I mean, look, we are a national health service, and the word national is important. And when you have a national emergency, like within a pandemic, I do believe that our strength is being able to respond to that as a nation. In fact, I believe that we can do much more in responding to the pandemic as a four-nation UK response. So I do think there's something very important about being a national health service, and for patients themselves to have the assurance that wherever they are in the country, they should have access to equitable care. And we need to plan and make sure that services are regionally planned to be able to deliver that care. But so I think that's important. Having said that, we also need to have, of course, local flexibilities in how we deliver that care, because different parts of the country have different populations, different needs. So there needs to be a mixture of national oversight, national standards, a national framework with local deployment. I do agree with the question that I believe that the health service should be much more clinically led. I believe that doctors should have a much greater voice, as should other healthcare professionals. Those that actually provide care, are extremely well placed, and that doesn't happen enough. But I also think that we have a health service that needs to really change in the way its culture and the way in which it operates. I led a very major project in the BMA after I became council chair, where it was probably the biggest ambitious project we've done, trying to define a vision of what sort of health service doctors want to work in. It was we did a very comprehensive survey, and that was followed up by me going up and down the country, literally meeting doctors across every region in England, and I also went to the devolved nations to really listen to doctors about what sort of health service they wanted. And what they all wanted was to work firstly in an environment that was adequately resourced. 9 in 10 doctors told us they go to work afraid they'll make a mistake because they work in a system that is under-resourced, where they feel they're working in an understaffed environment. And what they then said to us is that if they make a mistake, 50% feel they will be blamed for systemic errors. As a result, they practice defensively. And because they feel that they'll be blamed, they don't speak up about patient safety issues because they think they'll be blamed. So the system actually doesn't then improve. So we have a culture that isn't designed to improve patient safety because of this culture of fear. Now, you'd have thought we'd have learned after mid-staffs, where in fact, Don Berbick, who did an amazing piece of work, I mean, he's an international patient safety expert. And when he spent 6 months looking at the Francis report in mid-staffs, his conclusion was, and these are his words, that mid-staffs, NHS staff are not to blame. That was his conclusion. He said it was systems, constraints that were to blame. And he said that fear is toxic for patient safety. And here we are, and you look at the Ockenden report and nothing has changed. Fear is still prevalent. And in fact, people don't speak out. So I think the culture has to change. The other thing that I feel, and I've certainly learned over the years, is that, and being, one of the great things about being a council chair, is I take a helicopter view where I'm not looking at the world through my eyes as a GP. But in many ways, when I was BMA council chair, I felt I'd gone back to university, because when I was at medical school, we were all one. We were all one. And then you qualify, and then we all go our separate ways. You become a GP, you become a surgeon, you become a physician or whatever, and you go your separate ways. But actually, we are one. And I believe the health service, the way the NHS is structured, the rigid barriers between primary and secondary care are really, I believe, damaging. They are damaging for the profession, and they're damaging for patient care. And again, as part of this project, something like, I think 60 or 70% of doctors said that division, that silo, is actually impacting adversely on the care of our patients. So my vision would be that you break down those barriers and you create a system where we actually are doctors on the same side. Henrietta, you're a psychiatrist, and you know what? Is it not illusory? Where does inpatient psychiatry end and where does community psychiatry start? Where does the community psychiatry stop and where does the general practice care for the patient begin? We actually provide care in an interdependent way, and to the patient, they don't see these silos. They go to a child and adolescent clinic today, they come to see me next week. They believe that I understand what went on the week before when they went to a hospital clinic. And that's not the health service we've designed. So I think that needs to change. But I also think,
carry on.
But I also think that there's a big role also around the use of technology and modernizing the health service. I believe there's a much greater potential for multidisciplinary working, retaining the role of doctors in what we should be doing, huge potential for teamwork, and patient empowerment. And I think there's a lot that can be done moving forwards. And in many ways, those lessons were learned in the first part of the pandemic, where we all pulled together as one. But I think we need to, or the government needs to really make sure we have a different paradigm moving forwards.
What a great leader you are. I want to sign up. Give me a piece of paper. I'll put my signature to it. Everything you've said is just so perfect. Before we move on, we've got a lot of questions, but I do just want to take a moment I'd like you to share with our listeners how hard it actually was for you to get into the training. I told you I was moved almost to tears when I read that story about you, and could you share that, and then we'll move on and talk more politics.
Sure. I mean, so I was schooled in the UK. As I came here at the age of 7. I went to I thought a good school. I went to Barts, London. I thought I had a very strong CV. And in fact, the first time I experienced discrimination was when I applied for my GP training scheme. And I should tell you, I chose general practice as a very positive career choice, and I've never looked back. And I so wanted to be a GP. And it's hard to believe, it was the most competitive specialty when I applied back in I can't remember, 1986. It was the most competitive specialty. And I got 9 rejections in a row when I applied for GP training. And I just was gutted. In fact, I could not believe it. And I went to my GP trainer and I asked him, and I said, what has gone wrong? What's deficient in my CV? And he was honest enough to tell me, do you know what, Chaand? It's your name. Now, you know, today we have systems of equal opportunity in how you select people applying for medical school and so forth. But in those days, there was no equal opportunity processes. And in fact, you'll remember Sam Beveridge's study that he did then, where he showed that if you apply with the CV with a foreign name, you're far less likely.
Yes, I remember.
So I experienced that in spite of a strong CV. And do you know what I did for the 10th interview? I applied to Charing Cross Hospital's GP training scheme. I went to Charing Cross Hospital, knocked on the door of the postgraduate tutor who was leading the selection process. And I knocked on his door, uninvited. I said, you don't know who I am. My name's Chaand Nagpaul. I want to be a GP desperately. I want to come to your vocational training scheme. This is my CV. Please look at it. So when I apply, you'll know who I am. And sure enough, when the shortlisting came, I was called for interview. But, you know, I was called for interview amongst 180 applicants for 2 places. I was delighted I was appointed. But, you know, I also researched when I had the interview. I prepared like for an exam. We had a green paper on general practice at the time. The government was introducing reforms. I knew more than the GPs who were interviewing me about the government reforms, because I'd actually labored to be so good at the interview that I wanted to be sure I'd be offered a place. And that's how I became a GP.
Thank you for sharing this. I hope, and I know everyone will be feeling just like me, you know, again, moved so much by what you've said. And I am so glad that things have, you know, definitely moved at least in the right direction, if not fully. Now, we've got lots of questions, so let me move on. So we're going to hop around now, because I'm going to take the questions in order. Otherwise, it's a bit unfair on people who might be on a different topic. So Evan Mensah says, what are your thoughts about the anonymized GMC referrals? I am not sure that we should be quite patting ourselves on the back with the anonymized GMC referrals, because the root cause that results in the referrals in the first place has not been fully addressed. Black, Asian and minority ethnic doctors are still disproportionately referred by the trusts and managers. Also, alternative methods are used in place of a formal disciplinary.
You know, I totally agree with Evelyn. And this is, for anyone's awareness, this was a BMJ article published a week ago that showed that if you anonymize referrals, you don't get the disparity, because the disparity at the moment is you're twice as likely to be referred to the GMC if you're from an ethnic minority, and 3 times as likely if you're an international medical graduate. And Evelyn's absolutely right. We shouldn't have to anonymize to actually have a fair system. And what I find bizarre is that we have an NHS where all of us pride ourselves and value a health service that treats patients equally, regardless of background. None of us would dream of treating patients anything other than fairly. And yet the NHS cannot treat its workforce fairly. You know, I just find that astounding and unacceptable. And so we have to have a system where we address the root structural causes that actually make the lives of so many doctors so disheartening and so painful. And this is something that the BMA represents doctors, and this is something that's very close to my heart. And I do believe this has to be tackled, has to be addressed, and we should never have to rely on anonymity for fairness. Thank you.
Mabs Chowdhury says, What do you think, with hindsight, should have happened to protect vulnerable doctors and staff, particularly when ethnic minority staff seem to be more at risk? We now know maybe respiratory genes more prevalent, predisposing to higher risk. One of my best friends died in April 2020, a Sikh doctor on Frontline, and I thank you for the moving memorial recently at the BMA.
Yeah, so we had a memorial just a couple of months ago in the BMA for the doctors who died, and I can tell you, for their relatives, we might be at the moment in a better stage of the pandemic, over the worst, but to them, their pain, their loss is just as raw today as it was then. And you know what, when we called this out at the beginning of April, what we said to the government was not just do an inquiry, but put in place risk assessments. I wrote 3 letters to NHS England. I wrote to the Chief Executive, Simon Stevens, and I was involved in many discussions where I felt, and we felt, that risk assessment should have been put in place immediately to protect those who were most vulnerable. It took until 28th, I think, of May, that was about 6 or 7 weeks later, where it became an edict or it became a directive to all NHS trusts. That was like 7 weeks that were wasted. So I believe that much more should have been done much sooner. There was also delay in developing a risk assessment tool, a calculator, to really try and determine what are the factors that put you at high risk from COVID. Race was one of them, but obesity was another. And in fact, we got so tired of waiting because nothing was being done by the NHS, the BMA developed its own risk assessment tool that we disseminated to trusts. But there is another factor here, which is that many ethnic minority doctors who died didn't die because of genetic reasons. They died because of the fact that many were placed on the front line unprotected. We did surveys throughout, so we have very real-time data here. You know, ethnic minority doctors told us in surveys they were 3 times more likely to feel under pressure to see patients without protection in those early weeks compared to their white counterparts. They felt far less protected, but they also felt unable to speak out. And when we asked them, why did you not speak out? They said, we didn't speak out because we were afraid of it affecting our career progression or somehow being targeted. Now, remember, these are doctors, and many of them who've come from other countries, who actually already suffer bullying and harassment at twice the rate of their white colleagues. They already feel that they're here to progress in their careers when they're already disadvantaged. They don't have the same career attainment in progression. So they don't want to rock the boat. There was a doctor who died in April, actually, and this actually did go into the media, so I'm not divulging any confidence here. And I spoke to the son, and he showed me emails of emails from his father, who was in a ward at the time that was not a COVID ward, but he knew that COVID was spreading to the hospital. He asked to be provided with a mask. He was denied it by his manager, but he didn't challenge it. So he went into the ward. The next thing, 2 days later, 4 patients on the ward had COVID. A week later, he contracted it and was on an ITU bed. I think about 2 weeks later, he died. Now, his son showed me the emails of pleading to be protected, but we didn't have policy at the time in the NHS to distribute masks in non-COVID areas. In fact, the other thing that occurred in the pandemic is, for the first few weeks until April, in the UK, our infection control policies were below WHO standards. I actually, called this out, or I brought this up when I gave evidence to the Health Select Committee in March 2020. And in fact, 2 weeks later, we had emergency meetings with Public Health England alongside the Royal Colleges, where the guidance was revised to actually be in line with WHO standards. So in fact, this doctor fell foul of that situation when he wasn't given the protection he needed. So when you look at the statistics of 84% of doctors who died coming from an ethnic minority, there were those sorts of cultural factors of being on the front line far more. Many of those doctors were SAS doctors. That means doctors who were literally doing a lot of clinical work. They didn't have managerial roles. So there were multiple factors, but one thing we have to learn, this must never happen again. It would be criminal for us not to learn. And we have to do something about the fact that in fact, these structural causes of not feeling able to speak out, not being able to challenge, not being able to say that I'm afraid that I'm not protected. We have to have a culture where people are able to do that and are supported to do that. and that we do the right thing and make sure that anyone in the health service is treated equally.
Chaand, is there a list, a to-do list the BMA has produced in order for us to tick the boxes, in order for you, the BMA, to feel that we are, if it happens again, going to be better placed?
Well, it's interesting you asked that, because we actually, the BMA, have at the moment, we're completing a lessons learned review, which will be published in the next couple of weeks, where we have done exactly what you've said. Now, with regards to pandemic planning, I mean, the one learning point is, first of all, make sure you have the stockpiles, make sure you have enough protective equipment. The second is have public health policy that is actually swift, decisive, rapid. Make sure you have a public health infrastructure that is absolutely fit for purpose. But also the other thing is make sure you have a health service that actually has the capacity to look after the nation. Because the other hidden impact of all of this was the impact on non-COVID patients. Because we didn't have enough, because we went into the pandemic without inadequate numbers of beds, without inadequate facilities, what we had to do between March and June was effectively, and you know this, the government said that all elective care and routine services had to stop. But what we didn't publicize, and we didn't hear on the press briefings, was there was an excess mortality, if I'm not mistaken, of something like, if I'm not mistaken, something like 20,000. And no one spoke about them. These were people who didn't get access to cancer care. In fact, in March 2020, I think only about 50% of normal numbers of people who would attend with heart attacks attended hospital. They actually didn't get that far. So we have to have a health service where you don't have to close down the NHS when you have to deal with a surge of new infection. You need to do them side by side. And that leads into the fact that we cannot carry on with a health service that has so few doctors per head compared to European averages, where you have so few hospital beds compared to European averages. We had a quarter of the ventilation capacity, ICU capacity, compared to nations like Germany. So I think now is the time to really make sure we do have the sort of infrastructure moving forwards. But also the other tick box for me would be, as I said earlier, a culture where doctors, nurses, and others are supported to speak out, where the health service actually thanks people for talking about things going wrong. Because by thanking people for what goes wrong is when you will learn, and you will then be able to put things right. And that's the culture we need, not a culture of fear. But also, I would, as I said earlier, break down the boundaries between primary, community, and secondary care so that we actually can get rid of a huge tranche of obstacles, bureaucracy, where patients are caught every day in the crossfire of issues around who pays for which prescription. I mean, that isn't a health service that we want to carry on working in.
I am so glad this interview is going to be on YouTube, because everyone's going to want to hear it. And just before I move on to the many questions, so maybe that to-do list that you're working on eventually could form the core of a conference that you might do, a whole day conference where we could all come and hear your thoughts on this. It's just an idea, but that would be amazing.
Well, let me tell you, Henrietta, that in fact, I've always believed in thought leadership. I think that, expecting the government to come up with a solution to the NHS is bound for disappointment. So what I did do, this vision we're describing, I did put it together. It's called Caring Supported Collaborative. You can look at it on our website. And I actually did invite government leaders, and they did come to BMA House. I don't think this had ever happened before. So we had events, there were evening events where Matt Hancock arrived. We had the CMO, we've had Priya Nizar, the Chief People's Officer, Simon Stevens came, and they listened to this vision. They've heard it. And that's why I feel it's frustrated when you've spelt out what's clearly the right thing for the nation, and yet you don't see change. And it's that sense of glacial inability for the NHS just to change.
I'm going to move on and ask you some more things, but the next two are comments, but I'd like to share them with you. Amy Heskett says, thank you so much for so eloquently expressing the concerns and emotion felt by many in the NHS and social care over the last 2 years. Discussing this via such an accessible platform signals the importance of sharing feelings for us to work through the emotions and hopefully processing the lessons. The next person is Ekaterini Kyriakou, who says, it's a comment, the worst thing about the care homes is I very much doubt the care workers had any support or extra mentoring about basic counter-infection strategies. Hand washing campaigns were too short. People were not told to touch the outside of their mask and wipe everything continually. Given all that inefficiency, it was so cruel to isolate patients with dementia who deteriorated without family contact. I think that's just a comment, but it was good to share it. Nicholas Stingley says, the mistakes made by the state in the COVID pandemic reflect an overly individualistic approach to health that reflects an I-focused societal culture. How can we change this to a preparedness to act as a society in the interest of all in our society? Now, you've sort of answered that. Do you have any more to say on that before I move on?
I mean, the only other thing I would say is that government had put forward a very false narrative between the economy and health. And what was obvious to many, to myself, was they were two sides of the same coin. That in fact, by actually containing the virus, by creating a more healthy society, the economy would flourish. And we saw that only recently, back in December with the Omicron wave, we saw how I think, EasyJet had to cancel its flights because people were off sick. And we've seen it throughout the pandemic that in fact, having high levels of infection were affecting businesses. In the summer of 2020, there were supermarkets that couldn't get their deliveries to be stocking shelves because there was so much infection. So I think one of the things that really, one of the, as I said, false narratives was to somehow think that the economy and health are separate. I don't believe that to be the case.
Okay. Susan Collett says, who is going to hold our government to account in preparation for a future epidemic?
Well, there will be, as you know, a public inquiry that's going to start. But one thing that we have done at the BMA, as I said, in about 2 weeks' time onwards, certainly by the end of June, we will have produced our own learning lessons review about the impact and the government's handling of the pandemic as it affected doctors and the health service. And I believe that we will use that as ready-made information to feed into the inquiry. So certainly we will do our bit, and I hope the nation holds the government to account. But I think it needs to be more than just holding to account. We need to be assured that lessons have both been learned and that action is taken to make sure we never have a repetition of a situation where we do so badly as a nation in terms of the ability to look after our population. So it's really important to have those lessons enacted. And I believe that those lessons don't have to wait 2 years. Much of what I've described, whether it's to do with the culture in the health service, whether it's to do with capacity in the health service, whether it's to do with public health measures, those things need to be happening now. And my worry is that now that we're in a quieter phase of the pandemic, and I hope this will continue, of course, it's almost like those issues aren't in the forefront of the minds of government. They do need to be in the forefront of the minds of government. This is the time to make sure we are properly prepared for any surge in infection. It may not be COVID. It could be a bad winter with flu. And we don't cope even with that, at the best of times.
David Eady says, during the 1990s, public health doctors were being decimated by the government and HEE. The same happened to other specialisms, such as STD. A specialty has been treated by government very badly by degrading their specialism. The BMA knew of these issues, but did little to support these Cinderella specialists. Why did BMA not act back then to support specialisms like these that were not then in the front line?
Okay, so I'll be honest, I wasn't, I'm not even sure I was a practicing doctor, perhaps going back to the 70s or how long ago the question's asking about. But I can tell you that from my end, ever since I've been involved in the BMA, I have spoken very loudly and been very outspoken about public health, for example. When I qualified as a GP, we used to have the director of public health who was a proper independent advocate of the population in my area. We had public health doctors who I used to work with, and we had them in our local primary care trust, local health authority. What happened in the late 90s and into the 2000s was that the government basically disenfranchised public health as a specialty. We've seen a real diminution in the numbers and the role of public health doctors. We've seen the government almost think that public health can be managed. And I have huge respect for our public health non-doctors and the specialists who are not doctors. But what the government has done is it has devalued the immense role of public health medicine as a specialty. And then more recently, we've moved public health completely out of the NHS in England into local authorities. And what I've seen in front of my own eyes has been this emasculation. I remember, in fact, in the early 2000s, there was when governments would put up documents around improving the public health, things like world-class commissioning. I did a keyword search, public health. It didn't even feature. And so the idea that public health doctors should be central to the planning of healthcare, equitable healthcare, seems to have vanished. Even today, as we speak, in terms of integrated care boards, you don't have a statutory place for public health doctors. It's advice, So I am absolutely agree that this is tragic, and I've certainly been very outspoken. As for other services like sexual health services, etc., having moved into local authorities, what we've also seen is they've come under the sort of cost pressures of local authorities, the caps they've suffered, and the budget cuts. And it's been a tragic, very, very short-term thinking that we've cut those budgets, and the population has suffered as a result. So absolutely agree with the sentiments expressed.
We've got a lot of questions, and I'm going to try and bat them to you in a sort of ping pong game, and you can just give me some answers if you feel you can. Emma Storr says, related to the fear clinical staff feel about working, how do we support our staff and social care staff so that they don't become burnt out and leave prematurely due to stress?
I think the first thing is we all should rightly be valued for what we do. We provide just extraordinary care, and I will say that this applies to care staff as much as it does to healthcare staff. We all go over and above, and there isn't value. There isn't value. The government doesn't, come out with a sort of just look at what's happened to GPs over the last few months and the way in which they've been attacked, the media assaults. We haven't seen a government come to the rescue to say, you know what? Thank you. We so much value what you do for us. We're going to, call this out. We're going to say that this is not right. That you're doing an amazing job. We don't hear that sense of value. But more than that, there are practical things that need to be done. We need to make sure that staff work in environments where they can actually do their jobs looking after patients, not trying to, for example, on a day-to-day basis, working in an environment where, as I said, 9 in 10 doctors feel that they're at risk of making a mistake because they're in an understaffed environment. We need the government to say, you should carry on working like that. And we're going to actually do something about having proper workforce planning. The government has rejected an amendment to the Health and Social Care Bill, where we'd asked, alongside many others, for there to be a statutory requirement to have a workforce strategy with transparency of the numbers of doctors and other healthcare workers that are needed for the healthcare needs of this population. Government have rejected that. So I think that those are things. You need to have enough rest facilities. Large numbers of doctors do not have a place to rest. And that's when they're doing shifts overnight. There was a time when doctors even had to pay to have a sleep in the next morning. That's fortunately changed. So there's all of that. I don't think it's right that healthcare professionals like doctors should be having to pay for their parking. I think, what sort of message does it send when you feel that you often have to pay even more than you would on the high street? I could go on, but you have to, I think ultimately, you have to allow healthcare professionals to be able to do their jobs, which is to provide the care that they want to for their patients. Because what you're seeing at the moment is moral injury. What you're seeing at the moment is doctors and other healthcare staff unable to do what they were trained to do, and being forced into shortcuts. And when you now look at even things like the pressure to reduce waiting lists and the backlog, there are doctors and nurses who know that some patients should not be discharged, but the pressure to vacate beds, for example, means that they will discharge patients too early. And it's that sort of stuff that actually can be very demoralizing, because it is moral injury. So, and you get round that by being open about the fact that this isn't acceptable. You become open about the fact that you have to have a plan in place that will give all of us assurance that we should see a health service that has the infrastructure that we deserve to work under.
Pamela John says, it's a question about ethnic minority doctors. It's very long, but I'll ask you the last bit. Can you highlight what was done about the disproportionately affected ethnic minority doctors, and how this will then have impacted on the confidence in our leaders?
So, you know, this is, again, an unfortunate sequence of events, because the review that we called for came out in July 2020. And in fact, the first review, which was from Public Health England, was very clear that structural racism was a major cause for the disproportionate impact. You then had a government response to that really took out the word structural racism and denied that this was a factor. And we still don't have any government publication that has acknowledged it. In fact, the government's response called the NHS a race equality success story. I mean, I was aghast. I wrote an editorial in the BMJ about this. I just could not believe it, because, you know, all the evidence shows that, you know, right from medical school days, you know, medical students have 4 times the rate of bullying and harassment from ethnic minorities. So it starts right at the beginning, right through to disparities in career progression. You know, last year, if you were a black doctor applying for a consultant post in London, you were 6 times less likely to be offered that post. So you have a government that was promoting this idea that there is equality, which there isn't. So my answer to that is that you can do something about a problem when you first acknowledge openly it's a problem. And that's not an issue of shame. You know, I've always felt that, in fact, the problem we have in the NHS is people are afraid about speaking about problems. You know, we all need to recognize that to fail is to be human. But the thing you do about it is you be open about the problem, and then you have an action plan to put it right. And I think that's perhaps the impasse we're at the moment, because we don't have that open acknowledgement that there is a very serious problem. So with or without the government, I'm very pleased that the BMA and many other organizations are taking this forward. Many of the Royal Colleges are doing some fantastic work. In fact, your own college, Henrietta, the Royal College of Psychiatrists, has got a fantastic mentorship scheme for international graduates who've come to the UK with ongoing mentorship, support, camaraderie that I know has made a difference. So we're taking things in our own hand. In the BMA, I've commissioned some work which is similarly looking to provide many greater tiers of camaraderie support to international medical graduates and to ethnic minority doctors. I've set up a national forum for ethnic minority doctors that is now engaging and giving voice to thousands of doctors on the ground who at least know they have someone there to look after them. Now, we shouldn't have to be doing that, but that's what we're doing.
Monica Bajar says, as a profession, we are overstretched, stressed and burnt out, but still trying to help out and do our best. But we can't make any mistakes. Are we not human? How do we get the word to the public that it is not the doctors, it is the system which is being brought down to its knees?
So right. And, you know, one of the things in what you said about my vision is that I, in my vision of the health service, I believe we need a new paradigm in regulation. And I've said this to the GMC, that in fact, I think the idea that you put an individual in the dock for problems that are contributed to by the system is just wrong. I mean, every single issue, every single safety event, for example, that occurs should always be looked at through the lens of the system first, and then consider the role of the individual within that system. Dr. Bawa-Garba's case was a case in point, where the hospital concerned had 79 safety incident action points when it did its own analysis. And yet the only person in the dock was an individual doctor. That is because we have a regulatory system, professional regulation, that can only judge the individual. I think we need a new system where you judge the safety event as a system, and the person involved or individuals involved are part of that assessment. And that needs a redesign of how we regulate. So I totally sympathize. And I also think it is just unfair that we should be in a system where we are at risk of medical errors so often. And the public do need to understand that these systemic factors is what puts their health at greatest risk.
Peter Njoku says, what practical steps can we put in place to break down those real barriers between primary and secondary care? Now, bearing in mind there are lots of questions, maybe give a briefer answer you would have done earlier in the interview.
I think the current system where the GP is considered the referrer and the hospital a provider of care is just completely illogical as a paradigm. You know, I'm a GP, I provide care, my hospital colleagues are doctors, they provide care, and I would have a system that didn't have money and flowing around the system as if with vested interest. And one simple example I'll give is that I would have every hospital equipped with electronic prescribing so that a doctor in hospital can see a patient just like I can as a GP, say you need this prescription, press a button, the patient can collect it from their local pharmacy of choice, wherever they are in the country, and avoid the need to say, go to your GP to pick it up. You wouldn't have, I would get rid of those sort of budgetary constraints because it's really, to the taxpayer, it makes no difference whether, for example, Ritalin, as an example, is prescribed by a psychiatrist or prescribed by me. It's the same cost to the taxpayer. What on earth are we doing asking patients to go and waste a GP's appointment simply to collect a prescription?
We have Dr. Addy now with quite a personal message. I would like to read it. Nice to see you again. I'm regular at BMA meetings. Although as a member and all throughout my medical career, I wish the BMA had helped me more than just through education, which I've been enjoying clinically more today thanks to the RSM. Despite years of contact, I've not managed to speak personally with any medically qualified doctor in our BMA, and some of the non-doctor BMA advisors I've liaised with have not ever kept promises to have consented discussion with my long-term supervising consultant surgeon, an RSM fellow. So I realize it's personal, but I thought it probably would be best just to, you know, read it out as well. Any message for Dr. Addy?
So if I understood this right, I think Dr. Addy was speaking about the service he's received in BMA. And what I would like to say is that I would live by the same standards wherever I am, whether at my GP practice or the BMA, as I would expect for anyone else. I believe that, and one thing I have commissioned in the BMA is to look at the services we provide. We are a trade union. Doctors turn to us at times of need and help that they need in employment issues they face. So we are looking specifically at the moment, in fact, at the service we provide ethnic minority doctors, an independent review. So yes, I think that it's part and parcel of being a member of a trade union that we should provide you with the best possible service.
Excellent. I've got two more. I'm going to fit them in. We're going to finish by 5 past. Gillian Lang asks, is the spread of private primary care providers seen in London going to be replicated in other parts of the country, accelerated by pressures on access?
I really hope not. You know, I didn't tell you, Henrietta, that when I qualified, I actually sat the American entrance exam at the same time. I was persuaded to do by a friend of mine who was doing so. I went to the States when I was a junior doctor. And when I saw the system there, I talked to some doctors who were relatives of ours, and I just saw how everything was so business oriented. And one of my cousins there had said to me, do I really need to go back to see my urologist? And I said, why are you even asking that? She said, oh, because he'll get paid an extra fee. And the fact she had doubt in her head of the motives of doctors made me feel I do not want to be part of a system where money changes hands. And in fact, you know, patients may question the motives of doctors. So I really hope we do not get to that point. I think we have a responsibility as a nation to make sure, and the government has a responsibility to make sure that we live to those values that the NHS was born with, and they're as real today as they were then.
Our last question comes from Harriet Mullins. Do you think it's time to look at medical school training of how students are trained to fit into a system that isn't feasible long term? For example, telling students that they have to take a history within 10 minutes to match GP timings. Rather, should we create a more open discussion of how we can make change to a system going forward, one to inspire future GPs and improve patient satisfaction, along with patient safety and job satisfaction? And before you answer it, my apologies to all the other people asking questions, but we've got through as many as we could.
I don't think we should be training medical students to work in unsafe environments. What we must be doing is sorting out the unsafe environment. Now, let me tell you, as a GP, 10 minutes is simply not enough to provide quality care for large numbers of our patients. And we are shortchanging them, and that's a systemic failing. And we need to address that. So I hope, and I really hope, that in the years to come, in fact, not even years, in the months to come, we put an end to the idea that 10 minutes is a satisfactory timescale for a GP to provide care to patients, especially those with multiple problems. So no, I think that the system has to adapt and change, and the government needs to invest in a health service to allow us to be providing proper, compassionate, safe, quality care to patients.
Chaand, thank you so much. This has been an incredible evening, an unforgettable evening. And normally now I would be taking you out for dinner, but I can't because you're on Zoom. So hopefully we will do that separately at a different time. If you just hold on for a moment, I'll do some housekeeping and then I'll come back to you. I'd like now to remind people these events are free. And you've all been enjoying them now for a long time. If you feel you can donate to us, to the RSM, it is a charity, an educational charity, and we would really welcome that. And you can scan the QR code or go on our website. I also want to tell you about 3 events coming up. Ben, if you could flash on the adverts. One is Jennifer Dixon in Conversation Live on May the 25th. The second one is Artemis Cooper on the 22nd of June. And there she is. And then we've got Tackling Inequalities on the 23rd of May. So that's obviously coming up quite soon. And that will be a very big day. So we hope to see as many of you as possible then. I'd like to thank you, Ben, for doing all the AV stuff, and you, Chaand, for coming tonight. And all of you, we've got a lot of delegates who have attended tonight and asked lots of interesting questions. And I think we'll say goodbye here. And thank you again for such a splendid performance from our lead BMA person. Bye-bye. Bye-bye.